Thank you so much, Ewan. Thank you, Sue. Really powerful, as always. Thank you to Ailsa. I'm a respiratory consultant, did a lung cancer clinic on Tuesday and had a patient come in who'd quit after seeing that advert, not having made a quit attempt for 50 years. So really powerful stuff going on. I'm hoping that what I can convince you is that this work stream has really evolved and nurtured from the ground up, and so is incredibly impactful. I've been trying to think of one that is politically sensitive enough to share, but there's many instructions from on high about how you need to do something different, work harder, do more, cut corners, save money, that you know where they come from and you want to do it. So things like virtual wards, we're told we must get people out of hospital quicker, they recover better at home and turn beds over. I get that. It's just much easier for me if all the patients are in one spot and I can watch them, and we know that they're safe and they're taking their medicine. So, you know, some things come and you know why. It's just really hard work. This is utterly different. The NHS accepting its role in prevention as part of the long-term plan and the embedding of recognising and recording smoking status at admission, offering treatment for tobacco dependence, temporary abstinence and converting that to quit attempts within our frontline NHS services has been an utter game changer on the ground for myself in respiratory services, but for colleagues across all clinical pathways. It has been so powerful and an utter privilege to work in it. So I'm hoping I can sort of, you know, show you how important and impactful that is on the front line, and then hand over to Rachel, my regional strategic smoke-free manager, who will be able to explain how we've sort of shared and embedded that and upscaled it across the region, putting us on a national platform of recognition, as Ailsa said. So huge credit to them. So it was, you know, a programme of work that the clinicians, the trusts are crying out for, the ICB needs, the region needs, but more importantly than anything, I think the patients, as Sue has said, want this, need this, deserve this. So when I first became a consultant, the person who retired ahead of me had a lady with COPD on his books who smoked, and was really very frail, just in her 40s, really very advanced disease. And I took over, and it was lovely to get to know her and a privilege to care for her. We were able to support a quit attempt for her, and actually, you know, that made a big impact on her life. She became suitable to get worked up for consideration of lung transplant. She shared one night with us, Ailsa Andy kindly came up to a ward late one night, somewhere in the throes of COVID and everybody being a bit delirious, but she offered to talk to us and do a piece for an ITV programme, and she was utterly unprompted and shared this, and it's one of the most impactful things I've ever heard. Oh, I'm so sorry.
I've been in hospital quite a few times over the past couple of years. I've been in intensive care due to COPD, breathing difficulties. It's just a big vicious circle. You know, when I get ready, I have to sit down and just take it slowly when I'm getting dressed. I have panic attacks because of it, because I can't catch my breath, and all because I've smoked, and I wish I'd never ever smoked. Biggest mistake. But it comes to when you get something like this that you realise, oh my God, why didn't I do it then when I was told? Because this is what will happen. I mean, I'm 49. I was young. I was what, 13? So I've smoked from 13, because that cigarette I would hold in my hand and pose now is really just another nail in the coffin. It's had an impact on my daughters. With the worrying, I feel guilty that they've worried. The impact of losing out on running around with my grandson, and he's nearly 4 now, because of my chest not being 100%, it is weak. So I didn't.
Thank you so much for speaking to us. You've been absolutely fantastic.
Sorry.
No.
Every cigarette I smoked was another nail in the coffin, were her words. She was crying out for help, and we did not have the services to give her. Sorry. I stayed in touch with her daughter, her grandson, kisses her picture every night, and they really miss her. She didn't get to transplant. We can do so much more for our patients than we are doing. Everybody here in the room is doing it, and so it's been a total career game changer to be able to offer these services. And when you think before of all the people accessing care, and it really felt like we're not giving them the one thing they really need. People coming in crisis in A&E at night, with mental health crises, overdose, self-harm. People so ill from the impact of smoking and terrified at being in hospital and destabilising chaotic home situations, worrying about carer responsibilities and money, and yet still smoking at the front door, people with lung cancer, people so sick, they're in type 2 respiratory failure, unable to breathe, and we didn't have things to help, and now we do. So in an utterly different position now because of the work of Task Force, ICB, NHS, the advocacy at Region, a really powerful position. And this is exactly our clinical bread and butter, isn't it? We like to recognise a condition, call it, and provide cost-effective, simple, accessible treatments to the people who need it most. And because of the work across this agenda, we've now got really robust guidelines. Sophia here with treatment pathways telling us exactly what to do, how to do it, and it has changed our narrative. We're not criticising or judging people. When people sit in front of me and they say, I'm sorry, I know I've done this to myself, I still smoke, I can say, well, we've not done enough to help you then, what more can we do? And it not only means that we can offer them an intervention at that moment, but if they fail, they feel brave enough to come back and try again. So we're in just a phenomenally more... just in a much better position now than we've ever been. I'm very lucky to this agenda. And this is how, so in my clinical scenarios that I see, my bread and butter, unfortunately, Tuesday is an all-day lung cancer clinic, and on Wednesdays, troubleshoot on wards, COPD, respiratory failure. So this is everything I see. And this is how impactful being able to identify and treat tobacco dependence is. So in the lung cancer cohort, we know lung cancer is our region's leading cause of cancer death for both men and women. It's an ICB priority that we treat it. Those patients are older, average age is in their 70s, they're multimorbid, and we've got real clear guidelines about what we need to do about them. That poor person, by the time they finally present, and a third of them come in a heap as an acute admission. They don't access the care that they should. They just turn up at hospital, and we're finding that they've got a lung cancer, and we're saying, you've got this diagnosis that you'll think is terrible. There's a lot of hang-ups with it. You have to have all these different diagnostic tests to get to the bottom of it, and we've got a matter of a few weeks to get you fit enough to have whatever treatment we're going to recommend, whether that's surgery or radiotherapy, often for people who really haven't been able to prioritise their health for the last few years. So it's a huge ask for them. Being able to offer them treatment for tobacco dependency and get them free of the harms from inhaled combustible tobacco is a game changer. Not only does it double their life expectancy, so more impactful than palliative chemo, it changes the conversations. Like I was saying, I can say, you've got these few weeks of uncertainty, a lot of stress, but there's this really important thing you and your family can be doing here, and I can help, and we've got products, and our teams are there, and the teams here who work with me will know this. Caitlin signed up a whole family in a lung cancer clinic last week. The woman we were diagnosing, her daughter, her granddaughter, would help all of them. It completely changes our relationship with people and is giving us the tool that we knew we needed all those years to help get people better. So very lucky to have it. And the same in acute respiratory admissions. So we know a third of hospital admissions are related to respiratory disease, and we see on the wards the same people coming time and time again. And for years, certainly stepping in as a new consultant, you're looking at people in extremis, they can't breathe, their oxygen levels are low, they're having the air forced in with a non-invasive ventilator, gasping, the family are terrified, the ambulance said, ring the hospital, see if they're still alive. Terrifying situation. No offence to the pharmaceutical range of things we've got, but sometimes an inhaler doesn't feel like it's going to fix this situation, and you get them better and sending them out. And if you haven't been able to resource them with the confidence and the right products and support to help them stop smoking, they're back in the next month. And that was all we saw as trainees and coming into a consultant post. Now we're able to identify the tobacco dependency, their addiction when they come in, provide appropriate products, support them, get them to it's a real teachable moment, make their care journey as positive as it can be, and really empower them to get the best possible outcomes. And for that patient group, it it really forms. It's often the first thing where they think, oh, you really trust me enough to do this. You know, you think I'm going to be able to do this. They feel more confident. You're giving them something, whether it's free products or a free vape. You're staying in touch with them after the discharge. So it really starts to build therapeutic relationships in people who need it the most. So obviously it matters for the patients. It has been a game changer for the consultants, the clinical teams, the allied health professionals, but for the trusts, you can imagine how much it costs delivering acute NIV. And when you're doing it to the same people, month in, month out, and we all know them all, we all, know their relatives' first name terms, to be able to do something that breaks that cycle and keeps them out of hospital, healthy, well, and enjoying life, has a massive impact on trust resource and winter pressures, that burden of acute respiratory admissions which consumes us in winter, and being able to treat tobacco dependency and get people free from the harms of tobacco. We know there's an evidence base. It reduces the risk of readmissions, and Fire's done a lot of work on that. So it's one evidence-based tool that we can have in all of our winter planning and policies going forward that makes a huge difference. So, in summary, the privilege and the opportunity to work as part of the Treating Tobacco Dependency Task Force, to get to work with all of you at Region, is huge. From a clinical perspective, it has allowed us to bring evidence-based, cost-effective treatments to the people who need it the most, who we were utterly failing before. And it redefines our conversations, our narratives, our offer of help, and our delivery models of care. It changes our relationships about how we work with our partners across systems. All of this and all of you has given us an opportunity to network, to share best practice. I know people in other trusts I would never have had the chance to meet before, that we share educational resource and training that we've never had before, and share and collaborate on professional development opportunities. In my place and in yours, I'm sure it's opened doors to being able to work better with our pharmacists who've led on much of this and really kind of taking the bit by the teeth, really helped us deliver a range of products at the time the people need it the most. I know every single member of our security staff who've been helping us with smoke-free sites, who are all ex-smokers and powerful advocates and ambassadors. I know my maternity colleagues I wouldn't have had a chance to meet before. And within our places, as I also said about our alliances, working with our commissioners, our primary care colleagues, our drug and alcohol services, all those relationships, that's what I mean. It's kind of underpinning the change in our relationship with all our colleagues, that we're delivering what people need in a way and across services in a way they need it most. And as a region, we're phenomenally lucky to have had the support of the ICB in this and for it to prioritise this through all of its clinical conditions, through the Prevention Board, through Healthier and Fairer. It has put us in a really positive position. So I feel desperately lucky to have been able to work on this for all of you. So thank you. I'll pass over to Rachel, who's obviously doing all of the work behind the scenes to pull this together and summarise how as a region we've been able to channel this and deliver it out at place. Thank you.